Namaskar and welcome to the topic of biopharmaceutics and pharmacokinetics. Today we will see into what are the factors which basically affect the kinetics as well as the biopharmaceutical performance of the drug. So these factors basically are taken into consideration while we design the dosage form. So the particle size, the porosity, the partition coefficient, the solubility, the ionization potential, the pH sensitivity, the pH based solubility, all these factors are important, and they not only are responsible for the better bioavailability, but also from the biopharmaceutical point of view, because they help in the absorption, better distribution, better metabolism, lesser metabolism and elimination of the drug. We would understand the fundamental concepts of ADME and the impact on drug kinetics. We identify the physiological factors affecting drug kinetics and evaluate the physicochemical properties of the drug. So, the factors which affect the drug absorption. Now, the drug gets absorbed from dermal, vaginal, rectal, parenchymal and GI sites. So, the dosage forms as well as the dosage form characteristics play an instrumental role on how and to what extent the drug can be transported or get absorbed across these specific absorption sites. So, the absorption, as we have seen, that the absorption can occur by passive as well as active, and most of the absorption in the body occurs by passive diffusion. So, the physical factors basically of the drug are important in increasing or decreasing the absorption of the drug across the membranes. So, the first of the factors is solubility. So, for the drug to be absorbed, it requires to be solubilized, to be in solution state at the absorption site, and the dissolution of the solid dosage form is a prerequisite to absorption as well as the systemic circulation following oral administration, specifically for orally administered drug. Now, dissolution depends in part on the solubility of the drug substance in the surrounding media. Polar solutes are more soluble in water than in organic phases, while the reverse is true for the non-polar solutes. So, if the solubility of the drug is less, the absorption is less, and if the solubility of the drug is more in the water, the absorption is more, and the polar solutes dissolve more in water, and non-polar solutes exhibit poor water solubility. Ionized species have greater aqueous solubility in comparison to their unionized counterparts, and in the case of your pH dependent, that is weakly acidic or basic drugs which are given into the body, their solubilization is dependent upon the pH of the specific pH which is present at the absorption site. So, in the gastric juice, the drugs have a specific pH dependent solubility. In the blood, they have a pH dependent solubility. So, solubility as well as the nature of the drug, both are influential in determining the actual solubility of drug inside the body. Now, solubility of acids and bases in aqueous media is, as we have seen, pH dependent. Therefore, the drugs absorbed by passive diffusion exhibiting low aqueous solubility tend to have the slower absorption rate in comparison to those exhibiting high aqueous solubility. For drugs intended for topical application like vaginal, rectal, dermal, the solubility of drug in the vehicle is important, that is the carrier, pharmaceutical carrier, and for a given vehicle, the highest driving force for absorption is obtained when the drug concentration in the vehicle equals its solubility. So, the solubility of the drug in the vehicle as well as the solubility of the drug at the site of absorption should be almost same, so that the drug can move across and get distributed. Now, concentrations below saturation decrease the absorption efficiency, and while concentrations exceeding drug solubility serve as reservoirs to maintain a saturated solution. So, this acts as a depot. Then particle size. Particle size directly influences the surface area and hence its solubility. So, small particles have greater surface area, dissolve rapidly in comparison to larger particles. We are talking of the same material, large and smaller particles having same intrinsic solubility, but the solubilization rate at which the solubilization will occur would be more in the case of smaller particles in comparison to the larger particles. Particles size appears to have little influence on the absorption of drugs with high aqueous solubility, but a pronounced effect can be seen when the drugs have low aqueous solubility. So, many a times, since the solubility is a limitation factor, so drugs which have low aqueous solubility, they are micronized or taken to nano size range, so that the surface area can be effectively increased, and hence some improvement in their solubility can be observed, and hence their absorption, the rate of absorption of the drug. The absorption of grisofulvin, a neutral compound, is low, which is around 15 microgram per ml, is poor and erratic. So, increasing the particle surface area through micronization markedly improves absorption. Further reduction in the particle size by formation of fine solid dispersions in polyethylene glycol results in approximate doubling of the absorption efficiency in comparison to the conventionally micronized formulation. So, the micronization, solid dispersions, nanonization, these are few techniques wherein the size is reduced. Moreover, when we disperse them in any polymer like polyethylene glycol, which has very good water solubility, so this results in very drastic increase in the solubility of the drug, especially if the drug is belonging to poor solubility category. Then next parameter which influences the absorption is the crystal form. Polymorphs are crystal forms differing in the packing and orientation of molecules under different crystallizing conditions. So, their internal setup changes. So, the physicochemical properties of these crystals like density, solubility, melting point are influenced by their intermolecular forces. So, polymorphs with weak attractive forces are more thermodynamically unstable, are in high energy state, hence exhibit higher solubility than those with strong attractive forces. What it means is that the polymorphs which have a stabilized lattice are less liable to be dissolved, because they have a stabilized lattice means their energy is stabilized. Now, the polymorphs which have weak intermolecular forces need more energy to stabilize their lattice structure, and hence to achieve thermodynamic stability when they are exposed to any interactive surface like a solvent surface, they solubilize very fast. Now, this difference in solubility and dissolution and absorption rates of polymers need to be observed when we are going for dosage form development. When the difference in crystal energy are small, effects of polymorphism absorption may not be observed. For example, 3 polymorphs of chlorpropamide have been shown to yield comparable serum drug concentration, because these polymorphs had similar internal structure, and hence their absorption, solubilization, hence absorption were observed to be similar. Dissociation constant. Now, the unionized species of azotic or basic compounds in solutions penetrate lipoidal membranes of GI tract. So, only unionized species are able to transport across the membrane. The rate of GI absorption of drug is directly related to the concentration of unionized portion of the drug in the body at the absorption site. Now, pH is an important function which influences the rate of ionization of a specific drug. So, we have seen in the pre-formulation studies that pK is evaluated for the drugs to find out the pH at which it is likely to be ionized. So, the drugs with pK values from 5 to 7 are more readily absorbed than acidic drugs with high pK values. Amphoteric compounds manifest the least absorption difficulties when they are presented as Zwitterions, while neutral compounds do not exhibit pH dependent absorption. So, depending upon the pK value, we have to decide a specific pH at which the drug can be absorbed, and hence its site of absorption needs to be determined. Over the range of pH 1 to 8, the anionized fraction changes dramatically for acids with pK values between 2.5 to 7.5, decreasing with increasing pH, and for bases with pK values between 5 and 11, increasing with increasing pH. So, we see that as we go on increasing the pH, the anionized portion of the basic drugs will increase, and hence its absorption will increase. It is purely related with the how acids, at which pH the acids get ionized and at which pH the bases get ionized. So, we need not target that specific absorption site with that specific pH, so as to potentiate or facilitate the ionization of the drug, which in turn negatively impacts its absorption across the membranes, because only unionized drugs can move across the membrane. For the drugs with pH dependent absorption, there is a need to control by formulating the drug in a specific manner, so that their ionization can be controlled. So, their ionization is not happening. So, weak acids with pK values greater than 7.5 and bases with pK value less than 5 have pH independent absorption. So, we need to select those drugs if we have an option, or we can go for NCHEC coated, or we can make modifications in the dosage form, so that the ionization, the drug is not exposed to the specific pH, and we change the site of absorption of the drug. So, instead of the stomach, the absorption site becomes the intestine, or vice versa. Chemical factors like lipophilicity. So, the lipophilicity of the drug is important in how, in its in deciding how much of the drug can move across the biological membranes, because they are all phospholipidic bilayers. So, transport across membrane depends upon the lipid solubility of the diffusing species. Now, lipid solubility is determined by the presence of non-polar groups in the structure of the molecule, and as well as the ionizable groups that are affected by local pH. So, the unionized drug species exhibit greater lipid solubility in comparison to the ionized species. So, we see that it is opposite. Ionized species have better liquid solubility, aqueous solubility, whereas unionized species have better transportation across the lipid membranes. So, the relative lipophilic to hydrophilic properties of the molecule is desired, and this is described by the partition coefficient. So, and this further decides whether the drug will go by passive diffusion across GI or it requires an active transport, because ionized species are as well transported by the across the membrane by active transport mechanism. Lipophilicity of the drug further determines to what all areas in the body it can go. So, generally drugs which are lipophilic can, preferably those molecules which have high lipophilicity, are observed to have high bioavailability in the brain, because they can easily cross the blood-brain barrier. A high lipid solubility, however, does not necessarily favor absorption until the water solubilizing capacity of the drug is also good. So, if the drug has poor water solubility but has a good lipophilicity, it will not be absorbed, because it will not be available at the absorption site. On the other hand, when the water solubility is too low, a significant concentration gradient cannot be achieved at the membrane site, and the absorption may be inefficient despite the favorable partition coefficient. However, high lipophilicity ensures increased membrane permeability, better absorption and tissue penetration. Drugs with excessive lipophilicity have poor solubility in the blood, and they have a risk of accumulation in fatty tissues. Low lipophilicity means poor absorption, because they cannot, though they have good aqueous solubility, they dissolve at the absorption site, but they cannot move across the barrier membrane, and hence their distribution is limited. So, the partition coefficient, which is a measure, log P, which is a measure of partition coefficient. So, the drugs with log P greater than 1 are lipophilic, less than 1 are hydrophilic, and hence their absorption and distribution varies, and we need to make sometimes structural modifications in the drug so as to balance the hydrophilic as well as lipophilic character of the drug. Then stability. Chemical integrity must be maintained until the compound is delivered to the intended site of absorption or application. That means it should be stable not only in vitro but in the in vivo conditions. The chemical instability in the dosage form or instability poor to transport across the initial biological membrane invariably affects the bioavailability. Now, what are the factors which affect the stability? For example, pH sensitivity. Acid labile drugs degrade in stomach. Salt formation, a chemical modification that usually enhances the aqueous solubility. Chemical instability is often a function of pH, wherein the pH is most of the times as the culprit. Compounds that are highly labile in neutral range are seldom useful as drugs. Even the drugs which get degraded at a neutral pH range are not useful. Whereas instability in the alkaline range is seldom encountered under physiological conditions. Stability in acid is a concern, that is why we formulate the entry-coated tablets, and this is widely observed, particularly when the drugs are, and should be considered when the drugs are orally administered. Then oxidative and hydrolytic degradation. Vitamin C is sensitive to oxidation. Storage, exposure to light, temperature and humidity can reduce the drug effectiveness. Then next comes the metabolic factors. These are the factors which transform the drug mainly in the liver via enzymes. Now, the factors which affect metabolism could be genetic factors, like some are fast metabolizers, some are slow. Enzyme inhibition or induction, maybe the patient is on some other drugs which have the tendency to inhibit or induce few enzymes, which can lead to rapid metabolism of the drug in case it is induced, and if it is inhibited, there can be drug accumulation in the body. Then liver function, impaired liver function slows down the metabolism. Next comes the gastrointestinal tract, from where the drug is absorbed, and determines how well the drug is absorbed and utilized. Key GI factors like pH variation, weak acids absorb better in the stomach, weak bases absorb better in the intestine. Food drug interaction, which is also a GI parameter. So, some drugs are taken with food and some are empty stomach. When taken with food, like griseofulvin, because food increases the stay time and hence increases the absorption, along with it sometimes provides the necessary environment which can help in solubilization of the drug as well as absorption. Enzymatic degradation, some drug break down before even absorption, like insulin is destroyed by the digestive enzymes. Then comes the GI transit time. Slow gastric emptying delays absorption, example in diabetic patient. GI transit time, that is for the rate at which or the time for which the drug stays in the body is important. It can be both ways. If we want to increase the absorption specifically of the poorly soluble drugs, we can delay the gastric emptying rate. However, if the drug, if the food interferes with the absorption, then we need to give the drug empty stomach, and the gastric emptying time should be faster. Then the biotransformation can occur in gut lumen, gut wall or liver. Drug metabolizing enzymes are found in the upper intestine, which also have an impact on the stability of the drug. The metabolism of drug during transit through the gut wall also influences the bioavailability. Metabolizing enzymes are located in endoplasmic reticulum, mitochondria and cytosol. This we have already seen in the previous lecture. Some enzymes such as phenol, estrone, sulfokinases exit through GI tract, while others may be more localized in the jejunal mucosa like steroid alcohol sulfokinase. So, these enzymes are responsible for the metabolism of the drug. So, these enzymes could catalyze pre-conjugation reactions such as oxidation, hydroxylation, dealkalization, NS oxidation, reduction and hydrolysis, or they could be conjugative or synthetic reactions which can be triggered by these or which are being mediated by these enzymes. Then the physiological factors, the physiological conditions at the site of drug application, residence time of the drug at the site, shunting through the body fluids also influence the drug entry into the systemic circulation. So, first the route of administration or site of application. So, a larger effective surface area of the site of application influences positively the absorption specifically of the orally administered drug. If it is topical, influences positively because you get a more larger surface area for the absorption of the drug to happen. The site where a drug is administered determines absorption, onset and bioavailability. Now, for example, if I give it through intravenous route, 100% bioavailability because no absorption is there and hence rapid action. Oral route, they are subject to first pass metabolism, absorption is there and distribution and then response, so slower onset. Inhalation, rapid systemic absorption, so we can expect faster onset of action. Transdermal, we can because a lot of intervening tissues are there, so we can use this for sustained release over time, for example in the case of nicotine patch. Now, the rate of penetration depends upon diffusion of drug from the vehicle to the skin surface area, surface pH concentrations and diffusion through the stratum corneum and supportive tissues. Now, the drugs can move along hair follicles, sweat glands, sebaceous glands and aqueous channels. So, as I said, in the case of your transdermal mechanism, there are a lot of intervening tissues and factors, and hence the drug there is a delayed onset of action. Sometimes we can delay it purposely and can help produce a sustained release effect there. Now, bioavailability is usually good following intramuscular and subcutaneous drug administration. Mostly a large muscle mass is chosen for intramuscular injection. Then the residence time, the time a drug remains in a specific organ, tissue or body compartment before elimination or redistribution is the residence time of the drug. The time for which the drug remains at the site of absorption thus affects its bioavailability. The effect is minimal with intramuscular or subcutaneous injection or with dermal application, since the drug is confined to the site of application. So, and these sort of formulations come under depot. Solubility is more in the case of your formulation in comparison to the tissue site. It can act as a reservoir, and since they are planned in a manner, or if they can support longer residence time, prolonged drug effect can be observed. Now, in the case where the residence time is less, there is rapid clearance. Specifically, we see in the case of your IV bolus injections. Then the physicochemical nature of the drug, type of formulation and site of absorption along with GI tract will determine the effect of delayed gastric emptying or decreased intestinal motility on drug bioavailability, along with the other parameters like what food has been taken, whether the patient is fed or unfed. With regard to rectal drug administration, residence time in the rectal cavity is governed by leakage, defecation and upward migration of drug into the lower bowel. That means the drug needs to be stayed there, and if the patient so the rectal cavity is also a perfused cavity. So, if the drug is getting leaked out from the cavity or defecation has occurred or the drug has migrated into the lower bowel, then the bioavailability can be hampered because the residence time of the drug has been compromised. The first two factors would reduce or terminate drug absorption, while the latter would increase drug exposure to first pass metabolism in the liver. The factors which affect residence time are thus lipophilicity. Lipophilic drugs have longer tissue retention time, protein binding. Highly bound drugs increase circulation time and molecular size. Larger molecules have slow clearance in the body. Shunting and recycling. Now, shunting refers to the entry of drug into body other than the blood, body fluid other than blood before or after entry into the systemic circulation. So, depending upon the route of administration and the efficiency of the shunting process, the drug might conceivably never appear systemically. So, it keeps on moving into other body tissues. For example, hepatic shunting, the drug bypasses liver metabolism, increasing systemic bioavailability. Pulmonary shunting, the drugs may avoid lung metabolism and get entrapped into the pulmonary circulation. The lymphatic system is a pathway through which the drug, having been absorbed gastrointestinally or parenterally, may be shunted only to reappear later in the systemic circulation. So, the lymphatic system is a major pathway for absorption of fatty substances from GI tract. About 1/10 of the fluid filtering from the arterial capillaries enter into terminal lymphatic capillaries. The shunt is particularly important for substances with high molecular weight because lymphatic capillaries are much more permeable than the venous capillaries. So, with this we conclude, or we come to the takeaways, that the understanding of the factors of the drug is important because it influences the drug kinetics, the availability in the body, and hence since the drug is moving between different tissues, it is binding to different tissues, it is getting shunted. So, and if the drug has to be given multiple times, which is the case for most of the drugs, so the idea of what can happen when the drug is not eliminated, it is there in the body and the second dose of the drug is given. So, this is important to understanding of these parameters is important to understand the movement of the drug as well as in deciding the doses of the drug for a specific dosage regimen. So, physiological, physiochemical, formulation related factors we have seen, they all impact the ADME, which in turn impact the bioavailability of the drug. So, in a nutshell, it is important to understand these factors so that not only the pharmacokinetics of the drug is understood, but as well as the safety aspects of the drug are understood, taking into consideration the patient factors, because as we see, liver impairment can have an impact on the metabolizing enzymes. So, all these factors in totality need to be understood while designing a dosage regimen. First of all, the dosage form type and hence a dosage regimen for the patient, so that a safe, efficacious therapy can be provided to the patient. Thank you very much for your patient hearing.